Next, I invite Dr. MARIAN PAULY. Again, she needs no introduction. She is a senior consultant in oculoplasty from Giridhar Eye Hospital. Madam will be telling a different story on proptosis.
Yeah, thank you, Dr. Indu, for I know the holidays. Other side, I think TOT is going on. Yeah. So when proptosis tells a different story. So here I'll present 70-year-old male with came to us with a bilateral proptosis since 2 years and decreased vision in the right eye since 2 months. So you can see the proptosis and you can see a mild congestion in the right side. So on examination, the right eye 6 by 18 N8 and left eye 6 by 9 N6. Right eye, the pupil reaction is sluggish, color vision is defective 15 by 21. And there is a motility restriction also. And right eye fundus, there is disc edema. And MRI showed muscle thicken involvement of all the EOMs. You can see the both sides inferior rectus is enlarged and right side lateral rectus is more enlarged. So he has got a long past history. He had this symptom started from 2019, diagnosed as euthyroid eye disease, and he had received IVMB 12 doses February 2019. Again 2020, again IVMB, then oral steroids. In March 2021, he had chronic cough, fever. Then at that time, patient was investigated for TB, though CB NAT was positive, and he was started on ATT based on this in now March 2021. So this is his thyroid profile over the last from 2019. So 2019 he had an subclinical, he had hyperthyroidism. 2021 he became euthyroid, but however all the antibodies were negative, that is anti-TPO and TRAP. So when the patient presented to us, so now we have got bilateral proptosis, looks like a thyroid eye disease. But the catchy thing is right eye lateral rectus is more enlarged. So we thought it's a thyroid eye disease and advised radiation, but however patient denied, and the patient has got TB also. So steroids is literally out of context. So in this case, the patient has got a long course of, if it is thyroid, this pretty long course, active phase, then predominant LR enlargement and recurrence on stopping steroid with an associated TB. So we thought we'll do a muscle biopsy. In fact, he was sent to our endocrinologist also whether it is an extra pulmonary manifestation of tuberculosis. So, however, to confirm the diagnosis, he underwent muscle biopsy. So either it is TB, lymphoma, or non-specific inflammation. So the muscle histopathology turned out to be lymphocytic infiltrate, no granulomas. The patient was referred to rheumatologist for further treatment and to the rheumatological evaluation. So concurrent investigation showed raised serum IgG4 that is very high, 928. Patient was started on MMF. And follow up, the vision has improved 6 by 12. Residual defective vision is due to his cataract. Color vision is improved. There is reduction in proptosis. Movements also improved. Clinically, the eye became quiet and inactive disease. So now, what is the diagnosis in this case? So we put the final diagnosis as thyroid-related orbitopathy with IgG4-related orbital disease. So this was literally interesting for us. We know something different is happening because in thyroid eye disease, lateral rectus muscle is the last muscle to be affected. And if it is affected, there is something else we have to roll out. So when I looked into the literature, then it became more interesting. TED and IgG4 related RDR both are autoimmune fibrous inflammatory disease in which Th2 lymphocytes play a dominant role in their development. And there are few articles elevated IgG4 levels in patients with thyroid eye disease and the clinical implications. So in this was very relevant for us. The patient may be older. In our case, it was 70 years and have got more severe disease and higher clinical activity score. So the thing is, IgG4 may play in the role of there's a role in the pathogenesis of TED also. So then again we looked into the literature. There are IgG4 staining has been described in OPRS 2015, but another opposing opinion came from from the Journal of Metabolism, that is IgG4 as a biomarker in Graves' orbitopathy. So in this, what they have said is Graves' orbitopathy with IgG4 levels, the younger age and diagnosis, in contrast to the other article, and has got a more severe course of disease with a higher clinical activity score. So in this patient was treated with rituximab in the article. So this was very interesting. And now how it just changed, we try to check IgG4 levels in thyroid eye disease and to see the response. If it is IgG4 is high, only thing IgG4 is little costly investigation. So this is the lesson which I learned. Done. Thank you.
Thank you, Mariam ma'am, for that insight.